Text 3. The neglect syndrome. There are few more dramatic sights in clinical neurology than a patient ignoring one half of his or her environment, including one half of a meal, or insisting that a paretic left arm is entirely normal, while that held by the examiner must belong to someone else. These examples of severe neglect syndromes manifest by spatial neglect and personal neglect with anosognosia, denial of deficit, respectively, are uncommon and a suitable subject for medical literature. However, lesser degrees of the neglect syndrome are common, especially in right hemisphere stroke, and have an adverse effect on prospects for rehabilitation and function. Therefore, any practicing neurologist likely to encounter patients with acute or subacute hemispherical lesions, the typical cause of the neglect syndrome, must be aware of its possible manifestations and must be able to confirm their presence at the patient's bedside. The neglect syndrome is a constellation of related lateralized deficits, including neglect of sensory stimuli, extinction of awareness of one sensory stimulus by another when both are delivered simultaneously, neglect of one half of an object or of space, recognizing that different reference points for left exist in this context, neglect of part of a person's own body, failure to move a non-paretic body part as rapidly or persistently as its contralateral equivalent, and failure to recognize that the function of one part of the body is, indeed, impaired. Although many of these features tend to occur together in individual patients, they are potentially dissociable, and each patient must have his or her own distinctive pattern of impaired and retained abilities elucidated and documented, to facilitate further monitoring, care, and rehabilitation. The neglect syndrome has proved to be a fruitful field for experimental neuropsychology and neuroimaging, and there has been considerable interest in practical techniques to ameliorate its effects, such as prism adaptation. Sensory aspects of the neglect syndrome. Sensory neglect. Sensory neglect is said to exist when the patient is not consciously aware of or able to respond to a sensory stimulus contralateral to the lesion. In the absence of a deficit in the relevant sensory pathways or its cortical projections sufficient to prevent apprehension of the stimulus. This defect can be unimodal, but it may affect vision, touch, hearing, and even olfaction together. It can, of course, be difficult to determine whether a patient has neglect or a primary sensory disturbance. However, as pointed out by Heilman and colleagues, 2003, the bilateral nature of the central auditory pathways makes the diagnosis of auditory neglect easy. A patient with unilateral deafness will hear a sound applied to the deaf side in the good ear if the sound is loud enough, and unilateral cortical lesions typically do not cause deafness. Complete hemianesthesia is uncommon with hemispherical lesions, apart from those involving the thalamus. A patient with a thalamus-sparing cortical lesion who has hemianesthesia probably actually has sensory neglect. The olfactory pathways are uncrossed. Hemanopia, particularly hemanopia plus neglect, is the most difficult to distinguish from hemineglect alone. Patients with hemanopia without neglect are often aware of and compensate for their deficit, deliberately scanning into their area of field loss, but even the use of examination techniques such as supramaximal stimuli, e.g., bright torch in a dark room, may leave room for doubt. Extinction, or sensory extinction to double simultaneous stimulation, is said to be present when the patient does respond to sensory stimulation on the contralesional side but then fails to do so when another stimulus is applied simultaneously. The extinguishing stimulus is typically similar to that being extinguished and is usually applied to the corresponding contralateral area, but transmodal extinction, e.g. of a left-sided tactile stimulus by a right-sided visual stimulus, can occur, as can extinction of one stimulus by a second ipsilateral stimulus. When this occurs, the rightward stimulus typically extinguishes that further to the left. This allocentric effect can be seen in the ipsilesional as well as the contralesional receptive field. Extinction, too, may be unimodal or multimodal. Allisthesia. Allisthesia refers to the tendency of a patient, without other evidence of right-left confusion, to report contralesional, left-sided, stimuli as having occurred on the ipsilesional, right, side. Thus, when the examiner stimulates the left leg, the patient may be able to point to and move the left leg correctly when asked but reports that the right leg was touched. Edward Byrne et al. Neurology and Clinical Neuroscience. pp. 73, 74.